Hello, welcome to today's webinar, Who, What, Where, Clinical Sites for Transitional Age Youth Addiction Treatment. This webinar is produced in partnership with the ATTC Network Coordinating Office, AMERSA, and the Adolescent Expert Project by NORC at the University of Chicago. This webinar is part of the Transitional Age Youth webinar series. Sign up for these other titles. Today's webinar presenters are Dr. Veronica Masheryakova, Shannon Mountain-Ray, and Andrea Dickerson. Dr. Masheryakova is an assistant professor of pediatrics and adolescent medicine at the University of California, San Francisco, and the director of the UCSF Youth Outpatient Substance Use Program, a multidisciplinary family-based program that provides comprehensive assessment and evidence-based outpatient treatment for youth with substance use disorders. She also directs the UCSF Youth Addiction Management Training Program. Shannon Mountain-Ray is the Director of Integrated Care for the Adolescent Substance Use and Addiction Program's Primary Care Program at Boston Children's Hospital. Ms. Mountain-Ray is a clinically trained social worker who has worked with adolescents and their caregivers in various capacities for over 20 years. She has served in direct care, supervisory, and administrative roles throughout her career. Andrea Dickerson is a licensed therapist and certified substance use counselor who has worked in behavioral health for over 20 years. She specializes in working with adolescents and their families. Andrea is also a CARF International Surveyor, ensuring behavioral health organizations across North America are meeting required standards. It is my pleasure to introduce Veronica Masheryakova, Shannon Mountain-Ray, and Andrea Dickerson.
Thank you so much for the kind introduction. I'm very excited to be here and to be discussing this topic. So for the objectives today, we're hoping that after completing this activity, learners will be able to describe why early addiction treatment is so important, outline unique aspects of addiction treatment as it applies to transitional age youth, describe the ASAM levels of care and placement criteria for transitional age youth, as well as talk about some evidence-based practices that can be used at each of the levels of care. So first, substance use and addiction are really a pediatric priority because we know that adolescence is a very vulnerable period developmentally, and adolescents are at increased risk of the developing substance use disorders. They have a fully developed pain and reward pathway, but they have an immature prefrontal cortex. And if you recall, the prefrontal cortex is the part of the brain that allows us to plan for the future, think about consequences. And so adolescents, for this reason, are at increased risk. And here is a slide showing the developmental trajectory of the brain as it progresses from childhood to adolescence. And what this slide illustrates is that the prefrontal cortex is the last part of the brain to develop. And what we also know is that adolescents are the group that's most likely to experience health consequences related to substance use. And these consequences may include accidents, dating violence, risky sexual practices, as well as the development of substance use disorders. In fact, just at the end of March, Nora Volkow and colleagues published a letter to the editor in JAMA Pediatrics describing the increased risk of adolescents and substance use. And this letter talks about their original research that shows that adolescents who start using cannabis early, 10% of them may develop a substance use disorder within 12 months. So this is a really critical priority for us. And we also know that addiction usually starts in adolescence. 90% of adults who suffer from a substance use disorder started using substances before they were 18, and the vast majority developed their substance use disorder before they were 20. We also know that younger age at first substance use is one of the strongest risk factors for the development of a substance use disorder. So here we look at what happens with alcohol use, for example. Those who have their first drink before age 14, 15% of those people will develop a use disorder, as opposed to youth who delay their first drink until they're 21 or older. Look at what happens. Their risk of developing a use disorder goes down to about 2%. And this is also true for prescription drug use, right? So youth who first misuse prescription drugs before age 13, a quarter of those will develop a substance use disorder. Furthermore, we also know that earlier age of first use and when people get treatment can predict how long someone will struggle with a substance use disorder, right? So look at age of first use. So, youth who started using substances before age 15 may be ill with a substance use disorder for almost 30 years, as opposed to those who started using only after age 20. The disease duration is still quite long if they develop a substance use disorder, but it's only about 18 years as opposed to almost 30, right? And of course, timing of treatment is critical as well. A lot of people delay getting treatment for their substance use disorders, and those who don't get treatment for 20 years may be ill with their use disorder for 35 or more years, as opposed to those people who start treatment within 10 years of their first use. Their disease duration can be cut in half. This is why we're talking about early treatment for youth. And we know that early addiction treatment is effective. So this is a study that was looking at, it's a systematic review of studies that looked at various treatment models and whether they are effective. And as you can see, the bottom line here is that regardless of what treatment option is chosen, most of them are better than no treatment at all. Unfortunately, finding appropriate and effective treatment for transitional aged youth is quite difficult. And when we look at the availability of programs that treat youth, between 2003 and 2010, less than 36% of addiction treatment programs offered services to adolescents. And the number of those programs has actually declined during that time period. And adult addiction treatment programs often don't take into account the unique needs of adolescents and young adults. And that's one of the topics we'll be discussing here, is what's unique about this population. Finally, services that are offered at addiction treatment programs are often inconsistent and not necessarily evidence-based. That's the other goal of this discussion today, is really talking about what are evidence-based approaches to treating transitional age youth. So let's talk about general treatment principles for transitional aged youth, right? So generally, most youth with a substance use disorder will benefit from a combination of medical treatment as well as psychosocial interventions. The level of care should be chosen based on individual patient and family assessment and should start with the least restrictive level of care possible, right? So this is a really important fact. What I've seen in my practice is when an adolescent is struggling with a substance use disorder, a lot of times the parents or treatment providers will say, well, this child needs to go to a residential facility, they need to be sent away. And that's not necessarily always the most appropriate level of care, right? So really individualized and least restrictive. And FDA approved medications for nicotine, alcohol, and opioid use disorders are available for adults. They are not FDA approved for many adolescents, but may be used off-label. Now, an exception here is buprenorphine, which is FDA approved for youth age 16 and older with severe opioid use disorder. However, if you have a 15-year-old with a severe opioid use disorder, that is a consideration that a provider will have to think about. And so thinking about what's unique about treating transitional aged youth with addiction, first of all, treatment really needs to be developmentally appropriate, right? Not all teenagers are the same. And I divide adolescents here into early adolescence, middle adolescence, and late adolescence. And as you can see, each one of these age groups has its own unique characteristics that need to be considered when you're providing treatment, right? So early adolescence, they're going through puberty. There's a lot of changes. There's a lot of impulsive behavior. They're just starting that transition from the family group to the peer group. Middle adolescence, fortunately, there's some abstract thinking, there's some future planning developing, but this is the time where the adolescent will further separate from the family and really be focused on the peer group and maybe involved in a subculture. And increased risk-taking behavior. This is an important age group here because increased risk-taking behavior may mean using substances for the first time. And with late adolescence, there's further development of that prefrontal cortex. They may be starting to better be able to plan for the future. They may be getting closer to developing their personal identity. And the peer group may be less influential. So looking at these, in my practice, I really do find that middle adolescent age group tends to be, for me, the most challenging, right? Because this is where they're really trying to rebel and be part of their peer subculture and maybe less receptive to what their parents have to say. So these are all the considerations that we have to think about. The other unique aspect when working with transitional aged youth is that many youth will have very low internal motivation for treatment, right? So the vast majority of the youth who come to my program don't really see their substance use as a problem at all, right? Their parents are dragging them into treatment. They don't see it as a problem. They're not ready to stop using substances. And they're really still seeing a lot of the positive aspects of substance use versus someone who's maybe has been using for many years and has started to recognize the negative impact it has on their life. And because of this low internal motivation for treatment, adolescents also have low rates of treatment retention, right? So of course, if you don't think you need treatment, you're less likely to want to stay in. And adolescents can be really savvy, they can really talk their family members into, taking them out of treatment early, et cetera. And the low rates of treatment retention are, this is a big area of research because if we can get people to stay in treatment, we know the outcomes are better. And what we do know is that the treatment retention does vary by race or ethnicity. Adolescents with trauma history may discontinue treatment sooner. And this may also be affected by the type of substance used. So what we know is that adolescents who are just using cannabis, for example, are more likely to leave treatment early than adolescents who are using opioids, for example. However, what we do know is that treatment retention is improved if we're using pharmacologic treatment for things like opioid use disorder. So this is important. And the other unique aspect of treating transitional aged youth with addiction is engaging the family, okay? I think this is really critical, and we'll be talking about this throughout this presentation. We know that when family members are engaged, there's a reduction of parent-child conflict. The caregiver actually has improvements in their mental health. It improves rates of treatment adherence and completion, and it's associated with longer duration of abstinence from substance use and fewer return to use episodes or relapses.
Thank you, Veronica. So now we're going to transition to talking about the levels of care. So many years ago, the American Society of Addiction Medicine recognized the need to develop a national set of criteria providing evidence-based and outcome-oriented care for people with substance use and co-occurring disorders. So using a multidimensional assessment, which we'll describe in detail in just a bit, clinicians are able to consider things like needs, obstacles, strengths, resources, support structure, and other factors to help determine the appropriate placement along a continuum of care, which is outlined on this slide, highlighting 4 major areas in terms of outpatient services, intensive outpatient, residential or inpatient, and medically managed intensive inpatient services, along with recognition of early intervention strategies as well. So starting with the least intensive level of care, ASAM recognized that early intervention is an important opportunity along the spectrum. Early intervention is defined as assessment and education services for those who may have an identifiable risk for developing substance-related problems, but who may not meet criteria yet for a diagnosable substance use disorder. And we will talk about some specific examples of early intervention programs a little bit later. The next level of care is outpatient services, and this is the least restrictive level of care. It typically consists of 9 hours for adults or 6 hours for adolescents services, and is often focused on using motivational approaches to help people increase their desire and ability to make sustained and successful changes. And this level of care can be delivered in a wide variety of settings. Again, we'll give some examples of those a bit later. The next level of care are intensive outpatient programs, or IOPs. These are structured programs that provide more intensive services than outpatient programs and can provide support for a range of issues. Some examples of IOPs are programs that may offer services, for example, 2 to 3 days a week for a few hours at a time, and usually for a specific duration of time. Often intensive outpatient programs may be, 2 weeks to 4 weeks, or there are some that may be even as long as 3 months, but often there's a designated duration of time. They frequently offer options for evening and weekend care to accommodate schedule challenges such as work or school. The next level of care is partial hospitalization programs, and this is the most intensive level of outpatient care. It can be used as a transition between outpatient and inpatient or residential levels of care as both a step up or a step down option. These are structured programs offering 20 or more hours of service a week for people who may need more intensive services, but for whom may not want or require 24-hour levels of care. And then we move up to the residential levels of care, and there are a few different levels. The first being clinically managed low intensity residential service. These are programs that offer 24-hour living support and structure, and often have trained personnel on site, but offer minimal clinical service. So this is usually designed for people who may be in the community working or going to school or other kinds of activities in the community and may not need a high level of clinical support, but more help in terms of living, housing and structured support. The next level of care is clinically managed, population-specific, high-intensity residential services. This level of care only provides programming for adults. It is typically provides 24-hour care with trained personnel, and it's specifically designed for those who may struggle with cognitive or other impairments and who may not be able to actively engage in a full milieu or therapeutic community. Clinically managed medium intensity residential services also provide 24 hours of care with trained counselors and are focused on stabilizing a multitude of challenges, including imminent danger. And the hope is to prepare people for a step down to outpatient treatment. Patients in this level are able to tolerate full engagement in an active milieu or therapeutic community. Medically monitored high intensity inpatient services provide 24 hours of nursing care and the availability of physicians, although they may not be on site at all times. Patients usually require medication and often have a recent history of withdrawal management at a less intensive level of care, but may need inpatient treatment because whatever is going on for them, the challenges that they're facing are so severe, they need a high level of engagement by care coordinators. And then medically managed intensive inpatient services. These offer 24-hour nursing care and daily physician care for people who are struggling severely in the ASAM dimensions 1, 2, or 3, which we'll describe next. Counseling and other support services are available throughout the day to try to engage patients in treatment. And the goal is to stabilize patients with a plan that they continue care post-discharge. So now I'm going to turn it over to Andrea, who will discuss the ASAM dimensions of care and treatment matching.
Thanks, Shannon. As you heard, there are several levels of care that Shannon just reviewed, and sometimes it's difficult to determine what is the most appropriate level of care for the individuals that you're working with. By using the ASAM criteria, which is a multidimensional way to approach a case, you're able to determine what is the most appropriate level of care for at admission, as well as continuing on throughout treatment, and whether or not a higher level or lower level of care is becomes appropriate. This allows clinicians to move away from being kind of limited based on a diagnosis or having a one size fits all approach, and allows the care and the decisions on which level of care is appropriate to be based on that individual needs. We really want to be the least restrictive, knowing that out-of-home placements and those higher levels of care can be disruptive. And we definitely don't want higher levels of care to be seen as a punitive response to whatever's going on with the individual. So when it comes to the ASAM criteria, we do have 6 dimensions that we look at. Dimension 1 is focused on the acute intoxication and or withdrawal potential. And in this, we're looking at both past and current substance use and any withdrawal symptoms that an individual is reporting. And this is really looking at all substances that the individual is using, not necessarily the one that may have brought them into your office or your program. Dimension 2 is looking at the biomedical conditions and complications. This is really looking at the physical health, any current medication and why the individual is taking that, any recommendations from the last medical visits, efficacy of past medication, as well as compliance of medication that is prescribed to them. Sometimes for an adolescent, dimensions 1 and 2 are not the great areas of concern because they don't have as long of use history, or some of the substances that they're using have not been used as in such high quantities or frequency as an adult, but it's still, you have to keep an eye on these first 2 dimensions for sure. As we move on, there's dimension 3, looking at the emotional, behavioral, and cognitive conditions. This is looking at the mental health needs of the individual, any behavioral concerns, how are they doing in school, work, etc. If the juvenile justice system is involved, that you're going to want to take a look at all aspects of the individual. Dimension 4 is looking at their readiness to change. And this is really looking at that individual's motivation to make changes and where they fall in the stages of change. I have found, especially with adolescents, that this readiness to change can vary based on what substances they are focused on. And so they might have a substance that they are very motivated and they are really wanting to make some significant changes and potentially completely stop using, whereas others, they're still on the fence. And so I always like to be able to note if there's any significant differences based on those substances. Dimension 5 looks at the relapse, continued use, and risk of any continued problems related to that. So what is the current use of that individual? Are they aware of the relapse cycle, relapse triggers, warning signs? Are they attempting to abstain and have not been successful, or have they been successful in the past? And then dimension 6 is the recovery living environment. So for individuals that in the adolescence and transitional age youth, a lot of times that is still living at home with their parents. Sometimes it's with friends or on their own, but what is that environment like? Is it supportive? Is it, are people using in the home? What is the family's involvement and willingness to participate in treatment? We know that families are so important, especially when we're working with young people, that how supportive are they and how willing are they to come and be a part of treatment is going to be important, as well as how involved is this individual with any other healthy supports, and such as support groups, 12-step meetings, etc. When we look at those 6 dimensions, we then rate each of them anywhere between 0 and 4. And it's going to depend on what's going on with and what's presented to you for that individual. When you have 0s or even 1s, that typically means in that area that the individual is functioning really well. that there's really not a whole lot of disruption. There might be a little blip here or there, but for the most part, they're able to do okay right now in each of the 6 areas. But as we move up to a 2 and definitely to 3s and 4s, that is an indication that in that area, the individual is really struggling and is at a risk for not being able to function in their day-to-day life, that they're really struggling and at risk, and safety is starting to become an issue for sure. And that's when you're going to use then those ratings to figure out what for that individual is what's the level of care that's appropriate. The ASAM criteria really nicely allows you to be guided and to figure out where is going to be the best type of care for that individual to help them become successful. The ratings not only help determine what's that level of care that's needed right now, but then as they're involved in that level of care and that type of treatment program, are things going okay? Are the numbers staying the same, or are they fluctuating? As numbers lower, then a lower level of care may be appropriate. Similarly, if the numbers increase, a higher level of care very well may need to be considered. And when I get a new case and I'm looking at the ASAM criteria and the various ratings, I always focus and kind of zone in on whichever dimensions have the highest ratings, because those are the areas that I know that even if I don't have a whole lot of information about this case, I know that those are the specific areas that the past provider has thought is the most concerning. And that's an area that I can get started and focus on with that individual. Keep in mind the frequency of completing the ASAM criteria for an outpatient level 1 level of care is at a minimum monthly, whereas intensive outpatient or any level of care higher is a minimum of weekly. However, if anything significant happens to the individual, it's important to reevaluate and re-go over the criteria to make sure that it is still the appropriate level of care. So commonly, an individual will start off as at an outpatient level 1. And if you see, these are kind of the common numbers of ratings when somebody is appropriately in level 1 outpatient. Lots of 0s and 1s. As I said before, an adolescent sometimes doesn't experience much withdrawal. That's one of the ways it's different than an adult who's been using substances for a long period of time. Dimension 2 is also often a 0 or maybe a 1, because a lot of times the adolescents present and they're relatively healthy and they just haven't had the extent of life that has sometimes made dimension 2 higher for an adult. And for outpatient level 1, when we're looking at dimensions 3 through 6, there's not as much of a disruption in their ability to function right now. So we might have some areas of concern based on different dimensions, but overall, we're looking at a lot of 0s and 1s. We're at the low end of that rating. And as numbers increase, then it could indicate that a higher level of care is appropriate. So I'm going to introduce you to Jacob, our 17-year-old, who recently was caught drinking alcohol at a party and charged with a minor in possession. This is a very common reason why a teenager ends up coming in for a substance abuse evaluation. Mom is now concerned because of this charge, and she wants to get him evaluated and to figure out what's going on. Sometimes probation also will mandate that evaluation be done. In the course of the assessment, you find out that recently the grades are starting to decline in school, and he's starting to hang out with friends that mom's not aware of. So there's a change in peer group. And you find out that there's a conflict going on between Jacob and his dad. So taking in all that information, you then look at the 6 dimensions and you start rating where you feel based on that information where Jacob's presenting. So we have a 0 for both dimension 1 and 2, but then we start having 1s for dimensions 3 through 6. We're concerned about that change in behaviors, the change in his school and the grades, something that was not the case a few months back. He's showing some emotional distress because he's embarrassed based on this behavior and what's going on. As far as readiness to change, he seems aware and kind of connects the dots. So he is appearing to be kind of in contemplation stage of change. He's cooperative. He gets it. He's like, okay, I'll give treatment a chance. I'm willing to do it for now. Relapse and continued use, we're not quite sure. It's a 1. We're thinking moderate risk because that peer group is all using, and that's a new peer group, and we're still not quite sure what's going on there. And he doesn't really have a whole lot of information and education when it comes to relapse cycle and how to refrain from using. So that'll be something that we'll want to focus on. And then the recovery environment, that conflict with dad is definitely a concern. And we're not feeling like he has a whole lot of support outside of the family that's healthy. So based on all this information and where we're ranking each of the dimensions, our recommendation for Jacob right now is an outpatient level 1. Basically 1 or 2 individual therapy sessions a week, is hopefully going to be the trick. We're wanting to keep it least restrictive and least disruptive, but we want it to be an episode of care that is going to hopefully meet the needs and help prevent things from getting worse. The next higher up level of care that is common with adolescents is in the intensive outpatient level 2.1. And so what's typical when we look at the 6 dimensions for intensive outpatient is you're starting to move from the 0s to 1s to more 1s and 2s. And the more 2s you have, the more concerned you're going to be. And so once again, dimensions 1 and 2 might not have a whole lot. They might be still as 0s or up to a 1. But as far as looking at the dimensions 3, 4, 5, and 6, we're starting to get more concerned. There's more interruptions with the daily life. They're continuing to use, or they've tried to abstain for periods of time, but they've not been successful doing it long term. And they just are starting to need an increase in that supervision and support at home and then outside of home to be successful. So as an individual in an intensive outpatient level of care, as you're doing your weekly ASAM criteria, as you look, as if the numbers start to go down, you might consider more of an outpatient level 1. But as the levels go up, you're going to want to start considering a higher level of care. So we're back with Jacob. Jacob's been going to outpatient for a while, and every month you as the provider continue to evaluate where he's at with each of the dimensions. Unfortunately, he's not been attending your counseling very consistently, and when he comes, he's not participating the most. He is skipping out on curfew. He's coming home drunk and high, and mom's telling you she's just increasingly and extra concerned about the choices that he's making. School is not getting any better. It's actually getting worse. And now with the failing of classes, he might not be on target to graduate. And because of that conflict with his father is only getting worse. And the relationship is just even more and more conflictual. So if you see you go to do your ratings for Jacob and you notice that now we have a bunch of 2s, and even dimension 1, we're at a 1, because although he's not sharing and being open about his substance use, mom's collateral information is indicating that he's using substances more than he's reporting. And so we're not quite sure about where he's at within that acute intoxication or even potential for withdrawal. as you move through the dimensions, we are just really concerned about what's going on because it's not getting better. He's at moderate risk for continuing to use because he's spending all his time with his using friends in environments where substances are just readily available. And the recovery environment is really concerned. Mom and dad are starting to think like we can't provide the supervision for him right now. He's just blowing off all of our expectations and our requests, and he's not engaging in healthy support systems. So at this point, we look at everything and we're thinking outpatient level 1, a couple times a week is not enough. We are recommending that Jacob start going to an intensive outpatient level 2.1. So this means as an adolescent, he's going to be engaged in at least 6 hours of group and individual therapy a week. So then commonly with an adolescent in some areas, they'll have a partial hospitalization, but in a lot of areas, partial hospitalization is not readily available, and it's not accessible for families to get to. And so for some, commonly in my experience, an adolescent will go from outpatient or intensive outpatient right to residential level 3.5. So this is a residential setting where they live in the facility, and they have 24-hour supervision and care, not locked usually, but it is a highly structured and highly supervised treatment. So looking at the different ASAM ratings for residential care, we're seeing a lot more 2s, 3s, and maybe even 4s. This is showing that the substance use and the behaviors and what's going on is really a disruption. The individual is not safe staying at home. And although we want to do the least restrictive possible, there are times when safety is an issue, and an individual does need to be removed and go to an out-of-home placement and a residential level of care. And this is really to provide that safety, that control, that help them abstain and start to gain the skills that they need in order to start down the path of recovery. So Jacob, you've continued to meet with him at an IOP level of care. You're doing his ratings once a week, and they've stayed the same or they've started to get worse. And then you got the phone call that he got in a car accident and he was under the influence. And he's started to skip, is not attending all 6 hours of your program each week. And mom is concerned about everything that she's seen at home. And the school is really concerned because he's skipping classes. So things are worsening. And so as you can see, for his ratings for the 6 dimensions, we now are at a 2 for dimension 1. The quantity and frequency has really increased. It's evidenced by UAs and reports by mom. And he actually reported that he did black out the night of the accident. The biomedical is now a 1 because he did experience some minor injuries due to the car accident. And then the rest, 3 through 6, are now 3s because he's just really struggling, and he's emotionally appearing pretty hopeless, and his depressive symptoms are starting to increase. And it just feels like he's starting to go down a pretty dark path of the choices that he's making and how bad he's feeling about those, and feeling hopeless and unable to really lack confidence in his ability to be successful in making these changes. And evidenced by his continued use, we're very concerned about his risk of continued using without a higher level of care. So our recommendation at this point is that Jacob needs the out-of-home placement. He needs residential 3.5, 24-hour supervision. He needs to be able to attend groups and individual sessions daily. And then weekly, it'll be reviewed. And as his numbers start to go down and you start seeing more 2s between dimensions 3 through 6, then it could be possible that a lower level of care is now becoming appropriate, and you might then do the recommendation back to intensive outpatient or outpatient. But one note to remember or keep in mind as a clinician is that as discharge approaches, and if Jacob's been in the program for now a couple months, as he gets prepared to start going home and preparing for that discharge, some of his ratings might actually go up. Dimension 3 sometimes does go back up slightly just because there's an increased worry, an increased anxiety about that transition home. And so dimension 6 or 5 as well, just because leaving a highly structured, highly supervised program where he doesn't really have access to substances and then going home where he will be potentially, have an increased availability depending on the choices that he's making. That could also be a rating that starts to maybe go back up at the time of discharge. But that's all, as a clinician, a way to alert that outpatient provider. These are the areas that we're still concerned about, and we want to make sure that you're focusing on.
Thank you so much, Andrea. This is Veronica Masharikova back again with you. And the next thing we're going to talk about is evidence-based practices in TAE addiction treatment. So when people are in the various program settings and at different levels of care, what are some of the approaches that can really help them with their recovery? And we'll start with talking about evidence-based practices in early intervention, and I'll hand it off to Shannon Mountain Ray.
Thank you, Veronica. So I'm really excited to be here to talk to you about some of the new and innovative ways in which we are developing early intervention opportunities. I think it's helpful to start at the beginning where we began. So I am a clinician in the Adolescent Substance Use and Addiction Program, also called ASAP, through Boston Children's Hospital. ASAP started in the year 2000 and initially was an evaluation and referral clinic. Dr. John Knight, who started ASAP, who was a developmental behavioral pediatrician, recognized that there was a need to develop developmentally appropriate services for adolescents who may be using or at risk for using substances. And so they began with an evaluation and referral clinic, but very quickly realized that they could make as many referrals as they would like, but there were not a lot of resources available. So they developed an outpatient clinical program that is hospital-based at our main campus in Boston and also our satellite location in Waltham. It consists of an interdisciplinary team of developmental behavioral pediatricians, social workers, psychiatrists, nurse practitioners, a robust administrative support team, and also the first ever pediatric addiction medicine fellowship program, which we're really excited about. This outpatient clinic provides care along the spectrum of substance use. So for those who may have only used a substance once or twice to those who are using daily, and covers the broad spectrum of age from adolescent to transitional age youth. What we have learned, as successful as our outpatient clinic has been, is that while 4.5% of adolescents who are diagnosed with a past year substance use disorder, only a small percentage of them receive treatment. We also recognized that healthcare is an excellent opportunity to screen and talk to young people about substance use and health risks. This data comes from one of our pilot programs where their screening showed that 4 in 10 high school aged youth reported past year alcohol use, with 1 in 10 reporting binge use in the last 3 months. We also learned that 3 in 10 high school students report past year marijuana use, and about 1.5 in 10 report using marijuana monthly or more. And what we know is monthly use may correlate to a mild or moderate substance use disorder, and weekly or more use likely correlates to a severe substance use disorder. So understanding the frequency and being able to have resources to intervene is really, really important. So looking at Stacy Sterling and her colleagues' work, what we also understand in the context of using healthcare as a possible source of intervention was that there is an argument for integrating adolescent substance use care into areas such as primary care. There is good opportunity for prevention by using standard screening to identify those at risk before use escalates. There is good evidence for the early identification and intervention, which can show a reduction in use as a result of brief interventions. And specifically, a medical home model, which means receiving specialty care in primary care, provides an opportunity to offer care in a less stigmatizing way than in other environments. Stacy Sterling and colleagues also showed that rates of mental health and substance use disorders are affected by SBIRT intervention, screening to brief intervention. So this shows comparing adolescents who engage in SBIRT versus usual care. And what this shows is that the SBIRT group had fewer psychiatry visits at 1 and 3 years and were less likely to have a mental health diagnosis or chronic conditions at 1 year. And at 3 years, those in the SBIRT group had fewer total outpatient visits, were less likely to have a substance use diagnosis, and more likely to engage in treatment. So as a result of this, we at the ASAP program were looking at other novel ways that we could integrate substance use care for transitional age youth. So some of our efforts include integrating into primary care, creating telephonic consultation for primary care providers, and also providing virtual behavioral health treatment for young people who may want to engage in counseling. We also have initiatives for school-based vaping groups and a partnership with the Massachusetts juvenile justice system. I'll start first with our integration into primary care. So about 5 years ago, we were able to secure some grant funding to start to pilot an integrated model of bringing our ASAP outpatient clinic model into pediatric primary care. This shows I was actually the integrated social worker who piloted the program at Wareham Pediatrics. And this is an article that was written in the Boston Globe about our efforts. And that's Dr. Steve Mendes and Dr. Jason Reynolds, who were two of the pediatricians in the primary care practice that we integrated into. I'll just take a moment and highlight, while we were extremely excited to have recognition and the ability to amplify our work, the Boston Globe, and as well as what is true in discussions broadly, unfortunately used very stigmatizing language. And so I just want to highlight that, we would advocate using person-first language and avoiding stigmatizing language. So that's why you see the big red slash through the headline. But we were very glad to be able to share our work to the broader public. So for the ASAP primary care model, or ASAP PZ as we call it, we started with fully integrating an ASAP trained clinical social worker into the primary care setting as part of the multidisciplinary team. This program is office-based in each individual pediatric primary care practice, but does offer the same model of treatment that we use in our outpatient clinic. So again, covering the broad range of substance use from experimentation to addiction, and offering a variety of services, which includes medications for opioid, alcohol, nicotine, and cannabis use disorders, individual and group therapy, parent and caregiver guidance, as well as support for the primary care team. So again, this model focuses on providing care in the medical home We utilize the comprehensive biopsychosocial evaluation, medication, psychosocial treatment, and also referral and case coordination. For example, in the event that a patient might need a higher level of care, the social worker will work directly with the patient and family to help them access resources and also help them transition back to outpatient level of care. In addition to having the integrated social worker into the pediatric primary care practice, our entire interdisciplinary team at ASAP is a part of the process. So we provide extensive training to all of the medical and behavioral health providers in each of the pediatric primary care practices, and we also provide consultation and other sources of support. So for example, we ask that at least 2 or more of the pediatric medical providers be waivered to prescribe buprenorphine. And often these practices are engaged and very willing to do that, but have some trepidation about utilizing this treatment option for young people. And so we have had our medical director, Dr. Sharon Levy, has actually gotten in her car and driven down personally to these primary care practices and been on site as they do buprenorphine inductions to make sure that that providers feel very comfortable and are able to be successful in this, along with other things. If a provider is prescribing psychotropic medications to a patient and would like consultation with one of our psychiatrists on staff, there is direct access to be able to do that. So a lot of support by our specialty program in the pediatric practice as well. So this is describes the screening rates that's in some of our initial practices. So at baseline, you can see child health associates had the highest screening completion rate at 36.3%, but most of the other practices were much lower, some under 2%. When we integrated into these programs and we worked with the staff there around developing their screening process, around training them around the importance of screening and identifying patients who may have problems related to substance use, and providing them an opportunity to refer to the integrated social worker, you see screening rates really increase. So after the first year in many of these programs, you see significant increase in screening completion rates. You can notice Village Pediatrics, who had under 2% of a completion rate at baseline, were up over 92% after the first year. So really dramatic results and really increasing the opportunity to identify and refer patients to substance use care. In our pilot program, in the first 12 months, we had 60 referrals made from multiple clinicians in the pediatric practice, and 40 patients presented for at least an initial evaluation, and then many for follow-up after that. We treated 5 patients who were diagnosed with an opioid use disorder and induced them on buprenorphine, 3 of them on buprenorphine. Further down the road, 4 years later, we have recruited 17 pediatric primary care practices. We've screened over 6,500 patients, and we've had over 200 patients seen by a social worker. And we are continuing to increase and bring new practices on regularly. So another new and exciting way we are integrating care is to provide telephonic consultation to primary care providers. This is done through the MCPAP program, which is the Massachusetts Child and Adolescent Psychiatry Access Program. And pediatric primary care providers become members of MCPAP and are able to call their MCPAP provider and connect with an ASAP consultant to get substance use consultation. And this can be everything from helping them to understand how to screen, how to interpret results, what they should do with the results that they have. If they do want to prescribe medication, consultation around that. If they do feel like they need to refer them to a higher level of care, what are the options and resources to do that? So really helping primary care providers to manage patients who are struggling with substance use right in their primary care practice. As you can see, over the course, we started in December of 2019, and it's been a little bit up and down. You can see April, between January and April of 2020, there's the dip that we attribute to the pandemic, and then we have increased for the most part over time. With in the last month alone, we have jumped from where we were having about 8 patients a month to in the month between February and March, we've had over 17 consultations. And there are a couple of reasons why we believe that to be true. One is we think the word is getting out to more providers that the consultation service exists. And we also have added an additional service to the consultation line, which I'll describe in a minute. As a part of the consultation line, we have worked to create a toolkit for providers. So providing different resources on how they can intervene with patients in pediatric primary care. So this is one example of helping providers, giving them tips for addressing cigarette and vaping use, nicotine specifically. So in the first section, you see where they may give some advice and support. There are also guidelines for prescribing nicotine replacement therapy and what to do if NRT is not enough. Here is the table of contents for the toolkit, where we are covering a variety of topics, including specific substances, including specific interventions, and guidances for providers to be able to utilize with their patients and families. So that additional opportunity with the telephonic consultation program is that we are also now providing virtual counseling as a result. So if a primary care provider calls the consultation line, they describe the situation to the consultant, and if it seems appropriate, the consultant will let them know that we have virtual counseling available to patients and families to be able to access very quickly. So the real benefit of this is, number one, they can do the counseling from the comfort of their own home or wherever is safe and confidential, and they can have access very quickly. So this, I believe, has also increased. We've been doing a lot of marketing around adding this virtual counseling opportunity, and I think that also increased the number of phone calls to the consultation line. So in addition to the integrated primary care programs and the telephonic consultation, we've also created school partnerships to provide school-based virtual vaping group therapy. The group structure consists of 5 sessions and includes 2 trained facilitators, and the treatment approach includes motivational interviewing, mutual aid, and psychoeducation, and it's really based in the stages of change model. Some really exciting outcomes that we have had in our initial evaluations are that between midpoint and the final session, about over 90% of participants report that they have abstained for at least 7 days. So really significant behavior change and abstaining from nicotine use, which is really exciting. And then finally, our juvenile justice partnership. So we have connected with the Department of Youth Services in Massachusetts with the goal to improve the lives of youth involved in juvenile justice system and reduce recidivism by treating substance use disorders. This program provides a variety of services, including evaluation, medication, psychiatric assessment, follow-up, and bridge counseling for young people who may be in a juvenile justice program, but may be transitioning back into the community. And parent collateral history and parent guidance. So as was mentioned earlier, in all of these programs, there is the opportunity not only for young people to engage, but we also provide parent guidance, parent or caregiver guidance to be able to support caregivers in the process of supporting the young people. And so our juvenile justice program is no different than that. So now I will hand it off to Veronica to talk about the evidence-based practices for outpatient level of care.
Thanks so much, Shannon. It's amazing work that is being done. So if we recall our ASAM criteria, the least restrictive level of care for people with substance use disorder is the outpatient level of care. And so thinking about what that may consist of. The first thing that I'd like to discuss is monitoring. And when we're talking about evidence-based practices, certainly I always ask the question is, what we're doing, is it supported by the literature? Now, monitoring, which really is referring to urine toxicology monitoring, I would say is evidence supported. And the American Society of Addiction Medicine does recommend random urine drug testing to be used routinely in addiction treatment settings. Now, there aren't a lot of randomized controlled trials on whether urine drug testing improves people's lives and outcomes, but from the literature that has been looked at, it does seem to support recovery. But it has to be done very carefully, right? So the urine testing should be non-punitive. It should be used to enhance motivation and reinforce abstinence. It should not be used as the sole determinant of whether the patient is doing well, right? We have to really look at those other dimensions, how they're doing in their life, how they're doing in their relationships, and not just rely on whether they're having positive urine testing results. And according to ASAM, this is a particularly important aspect in outpatient treatment because the patient in residential treatment, for example, is sort of monitored for 24 hours a day, whereas an outpatient, we really are relying on the person to sort of report their substance use. And many people have lots of reasons why they may not accurately report that use. And so the urine drug testing can really help. And of course, in adolescents, this is really important as well, because adolescents also have lots of reasons why they may not report accurately. And one of those may be that they really just don't want to get in trouble, et cetera. The use of home drug tests is something that comes up a lot in our program. Parents start urine drug testing their kids at home. They say they went to a local pharmacy and bought a test and have been doing that. But this is actually not encouraged, shouldn't be encouraged. And this is because of issues with the accuracy of the tests and the interpretation of those tests. Okay, so as we're talking about evidence-based practices, pharmacologic treatment is the next on the list. And here's what we know, especially when it comes to pharmacologic treatment for opioid use disorders. Number one is that it improves patient survival, right? So treating an opioid use disorder with appropriate pharmacologic treatment saves lives. It also increases retention in treatment. It decreases opioid use and other criminal activity among people with substance use disorders. It increases patients' ability to gain and maintain employment. And it has improved outcomes for women who have substance use disorder and are pregnant. So pharmacologic treatment is something that is really an evidence-based modality. And as we mentioned previously, most youth will do best with a combination of medical treatment as well as some behavioral interventions. And when we're looking at what is evidence-based in outpatient level of care for behavioral treatments, one is just psychoeducation, really just talking and educating the patient and their family members about the neurobiology of addiction, for example. And some evidence-based interventions include cognitive behavioral therapy, motivational interviewing or motivational enhancement therapy, contingency management. For those of you who aren't familiar with contingency management, this is a very effective program, especially in the realm of stimulant use disorder, where patients receive some kind of monetary reward for either coming to program or submitting negative urine drug tests, where they get a gift card or some other valuable reinforcer. And then family-based modalities, of course, especially for our youth, are evidence-based and effective behavioral treatments. And this is a really confusing slide, but this is a study done by Tanner and Smith that really compared all the different behavioral treatment options for adolescent treatment. And basically, off to the left, there's no treatment. And off to the right are all the different treatment models that they compared. And the bottom line here is that any treatment is better than no treatment at all. But as you can see all the way over to the right, all the arrows point to family therapy. So this study showed that family-based interventions seem to be the most effective when providing treatment to adolescents and youth with addiction. And so at the UCSF Youth Outpatient Substance Use Program, we do our best to offer evidence-based interventions. And you know, I'm proud to say that a lot of, as we built our program, I had the pleasure of visiting Shannon's program in Boston and seeing what they do, and took away many of the lessons they learned and implemented our program. So we're a multidisciplinary family-based program for adolescents and young adults. We see patients aged 12 until they turn 26. And we're housed within the UCSF Adolescent and Young Adult Medicine Clinic. So we're a subspecialty within a clinic that already sees adolescents and young adults for a variety of other issues, including primary care. In terms of medical services that we offer, of course, we're doing the random weekly urine toxicology monitoring. We have expert interpretation available. We prescribe naloxone for opioid overdose reversal, and we educate patients and families on its use. We do provide outpatient withdrawal management when it's appropriate. And then, of course, evidence-based pharmacologic treatment for substance use disorders. So for youth struggling with opioid use disorder, we prescribe buprenorphine. For youth struggling with alcohol use disorder or opioid use disorder, naltrexone is something that we've used. We also provide pharmacologic treatment for co-occurring psychiatric conditions, as we know that these tend to be quite common. And of course, we provide risk reduction strategies and educational materials. In terms of those psychosocial services, what we offer, of course, is psychoeducation to patients and families. We provide referrals to evidence-based family therapy. We work with a community therapist and are currently working on hiring a therapist within our program. We provide parent guidance focused on safety and risk reduction. We help families develop behavioral contracts. And then we do provide referrals to higher levels of care when that becomes necessary and appropriate. And of course, a big part of what we do is really facilitating that interagency collaboration. So when one of our youth is struggling and needs to go to residential treatment, we stay in touch and we make sure that when they are ready to step back down to outpatient treatment, that everybody's connected. And we have a consulting addiction psychiatrist who provides consultation for youth with co-occurring conditions. Our program is fairly new, but I just wanted to share some of our outcomes. We took a look at our data between November 2019 and December 2020, at which point we had 42 youth who presented for an intake at our program. The average age is 16.8, and we have quite a diverse population presenting to our program. And after intake, over 70% of the youth and their families enrolled in treatment. And you can see the vast majority did engage in weekly drug testing, 60% received medication, and 50% received individual or parent counseling. And when we look at what are the most common substance use disorders that we saw in our program, cannabis use disorder is the most common, followed by alcohol use disorder, opioid use disorder, and benzodiazepine use disorder. And not surprisingly, we saw that youth really had a lot of co-occurring psychiatric disorders. So 77% of youth had a co-occurring disorder, the most common being depression and anxiety. And we found is that about a third of our youth reported experiencing some sort of history of trauma as well. And so looking at the outcomes for those youth, you know, like I said, over 70% enrolled in actual treatment. And at the end of the data collection period, 57% were still engaged in treatment or had graduated. We love seeing our graduates. You know, we really like to see people doing well for about 3 months and really in remission from their substance use disorder for 3 months. And at that point, if they are, we'll have a little graduation for them. And then looking at those that terminated treatment early, about 43% did terminate early. And as we know, this is really a significant problem for programs that provide treatment to youth, is early termination is common. And then we tried to complete a 6-month follow-up survey with all of our youth. However, we were able to reach only about 13 of those. And what we did see was reductions in substance use and improvement in their psychological and emotional outcomes. And now I'll hand it over to Andrea Dickerson again to talk about their program.
Thank you, Veronica. And I just really appreciate learning and hearing about both Veronica and Shannon's programs. YSS is a large youth-focused nonprofit social organization in Iowa. Started very grassroots back in '76 and started as a very child welfare and created the first emergency shelter for kids in the state of Iowa. And through the years, we've really grown and expanded based on the needs. And just last year, we've served over 6,000 individuals in our programs and over 10,000 through prevention and education services. And although we started as a shelter, shortly after that, we did start and created the substance use treatment programs. As you can see, we have a list, and this is definitely not an entire list of all the services that we provide at YSS. We have 4 divisions, and our outpatient and residential treatment all falls within our behavioral health division. But we also have the transitional housing, prevention and child youth development, as well as the child welfare divisions. And what makes me so excited and about the services that we're able to provide within our outpatient and residential treatment programs is our ability to collaborate within the behavioral health division, but as well as outside of it. Often our clients are coming to us and need other services that go beyond just that behavioral health treatment. And so we'll have individuals that will move into a transitional housing program or get outpatient services while they are in transitional housing. Occasionally we'll have an adolescent who's pregnant or parenting, and we can get them connected to our family development and self-sufficiency services. We have a lot of services within our prevention division as well that come in and help support and educate our clients on an array of topics. So it's just really, I'm really privileged in being able to do such collaboration. Our outpatient and intensive outpatient services provide anywhere from evaluations to individual and group counseling to family therapy and trauma-focused care. We use the MDFT model, which I'll talk about in a minute, as well as EMDR and TFCBT for the trauma-focused care. We have 6 clinics within central and north central Iowa. And in those, we provide outpatient therapy for both adolescents, transition age youth, and adults. We also have an office at Iowa State University, which is wonderful because it can help support and provide counseling to the Iowa State students as well as staff. And it removes that barrier of transportation. They can walk across campus and go to the counseling session rather than try to take a bus or drive over to our clinic in town. We also, a couple years ago, started to provide outpatient and intensive outpatient counseling to our juvenile training school. The adolescent males that are there often got involved with juvenile justice originally because of substance use, but unfortunately they sometimes have not had access to treatment. So we have 3 staff that are housed at the training school, and 100% of their caseload are those young men going through treatment. As I mentioned, multidimensional family therapy, or MDFT, is the family model that we utilize at YSS. I am a trainer of it, as well as certified therapist and supervisor. And I'm very passionate about the importance of the family involvement. I saw early on, working in residential, that our clients really struggled being away from their parents. And if parents were unable or unwilling to be involved, it was really a struggle to help the kid be successful long term. So that's why I love the fact that we use the MDFT model. It really focuses on not just fixing the adolescent, but really what does the entire family system need, and what are barriers for them to be successful. There are 4 domains within the MDFT model. The first is the adolescent domain. And this, we're really looking at how do we promote change within the heart and mind of the adolescent. The parental domain looks at how do the parents relate to each other? How do they co-parent? How are they as a couple if they're together? How are they as an individual? And so it's not just looking at them as parents, but are there anything that within themselves as individuals or as a couple that is creating a barrier that needs to be addressed? And sometimes, in my experience with the cases, we end up spending a significant amount of time with the parents only to help work through various struggles that they're experiencing. Family domain, that is looking at how does the family function? How do they communicate? How do they solve problems as a family? How do they show emotion and express love with each other? And then the extrafamilial is looking at how does that family connect with the outside entities such as school, probation, just in the community. And throughout MDFT, it's really looking at assessing and targeting the adolescent's ability to function within the 6 health-related domains. Because as we know, adolescence is such a time of figuring out who they are and figuring out their own identity, and sometimes staying, stepping away from parents and more with peers. And so looking at what that peer influence is and helping the adolescent figure out who is it that they want to become and be in the future. Motivational interviewing has been mentioned before, but thought I would go into just a little bit of detail of what is motivational interviewing. It's not a set of techniques that are in your toolbox as a clinician. It's really becomes your style, your approach, and ways that you're engaging with the individual. It helps you approach the individual wherever they're at, and embracing where it is that they're at, and then helping them and guiding them towards whatever changes are appropriate. There's the 4 aspects of MI, and it's really looking at acceptance, partnership, compassion, and evocation. It's a real mind change and shift in mindset if you work with the individual, and rather than doing treatment to them, you're helping them, partnering with them, you're collaborating with them. You also believe truly that they have the ability within themselves, and you're just going to help them bring out those strengths and move towards whatever success is. So it's definitely a collaboration. And I always like to note that sometimes an individual's motivation is going to fluctuate. I don't know about you, but I rarely make a decision that I'm going to make a change and I stick to it 100% forever. And so we just need to expect and embrace that some days motivation is going to be higher than others. So as I mentioned, our outpatient and intensive outpatient programs at YSS, we also have residential. And residential because we started as a child focused and have really stayed true to that, as far as an organization, we provide adolescents and adolescent only residential treatment. We're not an adult provider that has, you know, a wing of a few beds that are kind of a afterthought for adolescents. We really have stuck to focusing on that adolescent and transitional age youth. We've served over 5,000 adolescents through the years. And even this past year, due to the pandemic, when some of our bed capacity was shrunk due to the pandemic, we still served over 100 youth. So in the last 15 years, we made the decision that we were going to be a single gender treatment program. So we were not going to be co-ed. And so we have a girls facility in central Iowa that has 8 beds. We have a boys facility in central Iowa with 15 bed capacity. And then a couple years ago, we added a second boys program in northern Iowa that has right now the capacity for 12, but with some remodeling, we're going to be increasing to 16. We have an interdisciplinary approach to that treatment. And we really don't just focus on the substance use treatment, but we increase and help the individual look at youth employment, pregnancy prevention, sexual assault awareness, education. So we want to definitely support the individual and not just their substance use, but the whole individual. Couple last things I want to mention as far as our own residential programs is the importance of family involvement. We provide monthly parental education groups that focus on substance awareness, substance abuse awareness. Sometimes our parents don't really know a lot about substances. They don't always know a lot about what to expect and what's age appropriate for an adolescent. And sometimes they're just really struggling on how do you parent this teenager? And so providing some of that parent education groups, as well as utilizing the MDFT model to be going while their adolescent is in treatment, but then also when they return home. In the last couple of years, we've also extended our recovery supports to include an app, that HS app that we use, that really has been wonderful as the individual returns home to stay in contact, because we know kids love their smartphones. And that's the way to keep in contact. So they get alerts and they get reminders, and they also can reach out if something is concerning. Last is about our gender responsive programming. We really value the importance of being gender responsive. And so we're not just wanting to be single gender, but we really want to be intentional about the curriculum that we use. And so we have a couple, here's a couple of the curriculum that we use with our girls. The Women's Way Through the 12 Steps and Voices, they both really look at becoming healthy young women. How do you approach the 12 steps from a female perspective? How do you improve self-esteem? For the male curriculums, we use the Helping Men Recover and the Council for Boys and Young Men. And this is really a way to process topics about becoming a healthy young man. What has a father figure's been like in their own lives? What do they want to become as far as a young man? And how do you express your emotions? So it's really important for us to continue ensuring we keep gender in the conversation and being intentional when we're designing our current and future programmings.
Okay, so thank you so much. This is Veronica Masharikova back again. And practical issues in TAE addiction treatment is a very wide topic. And so just based on time, I chose one of the most common issues that come up in this treatment model. And that is when youth refuse to engage in treatment. So very often we get phone calls from parents that say, I'm really worried about my kid, but they don't think that this is a problem and they really don't want to come to a treatment program. So what can you offer people in that situation? And what I've really learned to appreciate is the community reinforcement and family training approach, also known as CRAFT. And this is based on a community reinforcement approach, which aims to help patients with substance use disorders to replace substance use with healthier behaviors through positive reinforcement. And this was designed for people who refused treatment, who did not want treatment. And so this is really a perfect model for those adolescents. And what we know is that this is quite evidence-based. It's shown to promote engagement in treatment in up to 2/3 of treatment-resistant people. That is an amazing number. And it actually enhances the happiness of the concerned significant other, like the family member. So just as an example of what this might look like, we use the example of Mary, a 19-year-old who has opioid use disorder and lives with her mother. And she is absolutely not interested in treatment. They have this tradition where they have Sunday breakfast together every week at 9 a.m. and they both really find this enjoyable. However, when Mary uses opioids on weekends, she typically doesn't come home or doesn't wake up early enough for breakfast. Previously, Mary's mother would wait for Mary to come home, even if it was 1 p.m., and then would still cook a nice breakfast despite feeling really frustrated about Mary's late arrival. But after CRAFT, Mary's mother has a new strategy. If Mary isn't home in time for 9 a.m. breakfast, she goes out for breakfast with a friend or goes to a yoga class, right? So Mary's kind of on her own for breakfast, and Mary's mother gets to do something that makes her happy. So this is really about kind of withholding positive reinforcement when someone is using substances and providing positive reinforcement when they're successful in abstaining. So it's a really unique and interesting model that really even helps the concerned family member. So I would encourage all of you to learn more about this CRAFT approach and to find providers in the community who may be offering this. And thank you so much for joining us for this webinar.
Thank you for today's presentation, Andrea, Shannon, and Veronica. To augment the information provided today, you can explore these additional resources from the ATTC and PTTC networks. You can also keep in touch with ATTC, NORC, and EMERSA via their newsletters and social media. Sign up to receive emails and follow them on Twitter and Facebook. Thank you so much for attending. That concludes today's webinar.